Hello, everybody. Welcome to podcast number 115. I'm your co-host, Susan Clinton, along with Erica Mello. And we wanted to just pop in before the podcast and share a couple of exciting things that have gone on in our premium podcast club. One of them is we have just recorded and put in our first Ask Us Anything. And it turned out to be a great discussion about a client that you will not want to miss. Also, we have show notes that are getting loaded from some of our most recent podcasts and some of our most favorite podcasts from before. So watch for those. Those are coming into our podcast club as well. And Jessica, tell us, I think we got, Erica, welcome.
Tell us, I think,
yeah, I do.
Exactly.
I think we got hers dropped in part one, right?
Yes, and it's so interesting because we've dropped in part one. There was a two-parter we filmed with Jessica Schwartz on concussion, and that was part one we dropped in the membership site. And it's interesting, I did a telehealth session with somebody yesterday, not local to me, and in her history was a concussion. And we learned great clinical pearls from Jessica. So for those of you who really want to, up-level your skills or change the game, as I would say, I urge you to join the club. It would really make a big difference in your clinical practice and your outcomes. And the URL is toughtotreat.supercast.com.
Yep. toughtotreat.supercast.com. Join us and enjoy the podcast. Welcome, everyone, to podcast number 115. I am your co-host, Susan Clinton, here with Erica Mello. Hi, Erica.
Hi, Susan. How are you?
I'm good. The winter months of February is upon us, and lots of people are getting a lot more colder weather across the country than they expected, particularly in the South.
I know.
But we're here and warm in our places, and we're going to bring you another podcast today. And this is going to be one that has a lot of similar presentations across clienteles that I've seen in the past. So what I did was I amalgamated this and pulled it into a case so that it will make sense as we kind of go through it. But I wanted to talk about some differentials around the T12L1 innervation group, mainly because that thoracolumbar area is such an area of transition. And we often see thoracic drivers above. We see hip and pelvic drivers below. We see, relationships with the neck and the foot and knee and all of these things at these different transitional zones. And I wanted to kind of just go through this because I thought it would be interesting. Plus, I'm hoping it'll generate a lot of discussion.
Yeah.
So this is going to be, I'm just kind of, like I said, I just kind of put together an amalgamation of stuff here. 55-year-old female. No real medical history or any problems, but a number of years ago had a nerve root lesion on the right side. So L5S1, kind of posterior lateral disc type of presentation with the pain going down, unable to flex, better with extension, the whole 9 yards, insidious onset. Did very, very well with physical therapy and injections. Got the injections to settle things down around the nerve root, the physical therapy, extension-based exercises that eventually went into flexion, and some loading and flexion, and she did very well. A little residual pain the bottom of the foot, but that's all kind of cleared up over time. What she did, so that was her past history. Her past history is kind of this insidious onset of left hip pain, anterior hip pain, as well as, I'm looking at my notes here, left anterior and left lower quadrant pain.
So same side as the nerve root lesion?
Nope, other side,
no,
side opposite.
Got it, okay.
And, and pain with walking, but with stride. So when she stepped forward with the right foot, that would bring on the left anterior hip or the left lower quadrant pain. So also after sitting for a long period of time, And then getting up, it would feel catchy and sore and, be painful. Stepping up a step with the right leg, brought it on the left. So you can see kind of that extension pattern in the left hip, was problematic. And then, but interestingly enough, twisting to the left brought it on.
In standing or sitting or both?
Standing or sitting or both. Yeah, interesting, right?
Yeah.
And I've kind of puzzled over this several times with
You're
clients. Yeah, but everybody's doing it now. It's like, wait, what is that? So
the opposite
so
of what
her
you would
movements,
think.
her movements. So when I just her pattern in standing was the trunk kind of shifted to the left. So if you think about, somebody who has an acute disc, they're going to have the lateral deviation. And she definitely, it's like that didn't go away or something, so that kind of got my attention right away with her history. Like her trunk was just kind of slightly displaced to the left. Her thorax. So, and she was standing more on the left side, a little bit more weight bearing on the left versus the right. So maybe a pattern that the brain was still afraid of. To stay off of an area, even though the pain is resolved, there may be some residual motor changing around that to make it less uncomfortable when she went through it. And, and if that was never changed, that motor pattern can stay there. It took a long time for all of that to heal up and clear up on her. She said it was about 6 to 8 months course from beginning to end by the time she started to feel good. So, it's a long time to have that and to have that situation going on. So so there was, my thought was, okay, this looks like maybe kind of that left lateral deviation that may be left over. Of course, you have to take your brain out of it a little bit and be curious and see what unfolds. So I had her just do, a basic bend over, and I just noticed that her trunk, actually, she went about halfway to maybe 3/4. Okay. And but as she got to that time, her trunk started to twist to the right. So her thorax was doing a right rotation. In other words, she was getting a right rib hump as she was, going over. And then as she was going further, she had to rotate. To do it. And she said that it bothered her a little bit in the front of her hip.
In her hip.
Yeah. And then so I had her do a squat. And it was interesting because when she went down, her pelvis pulled to the left, to the right, but her trunk continued to lean to the left.
When she went into a forward bend?
So a squat.
Oh, a squat, sorry.
So now, so squats, in order to get down, she could go about 3/4 of the way down, but she pulled her pelvis over to the right, so she was really squatting down onto the right leg.
Right side,
she stood on the left leg a lot.
It
meant that trunk stayed deviated to the left.
Got it.
Okay.
Yep.
So, and then of course, to try to figure everything out, I decided to get her into kneeling. It's like, let's take the feet out of here. I didn't think there was a foot thing, but it's like, let's get rid of the feet and see what happens. And she was unable to get into half kneeling without it bothering the left side. But she could get there after time. It just took her a minute or two to kind of get to where she could balance on both knees. And so then from there, and still the same kind of pattern, the trunk a bit deviated to the left, maybe a little side bent in the lumbar spine to the left.
Got it.
And when I asked her to put her right foot onto the ground and leave her left knee down, she was unable to do it. It hurt too bad. And she had a big trunk twist to the right.
Got it.
Okay.
Yep.
When we put the right knee down and put the left knee up, everything was fine. No problem.
That makes sense.
No problem. Yeah. Starting to make a little bit of sense here. And then I asked her we got back up onto our feet, and I just decided, let's just take a look at some side bending and rotation stuff, because I'm seeing a lot of this kind of twisting stuff.
The same movement pattern, right? We talked about that on a Facebook Live a while ago.
So she could side bend to the left, and she could rotate to the right. Pretty easily. She could not side bend to the left and rotate to the right. To the left. I'm sorry. She couldn't side bend. She couldn't side bend right and rotate left. So the opposite side she was unable to do. So when she side bent to the same side of her pain and rotated away, she was okay. When she side bent to the right and rotated towards the left, she had an extreme lack of range of motion, could not rotate to the left.
I got it. Okay.
Okay. Didn't really bother the pain too much one way or the other.
When you tested her, you said in sitting and standing, rotation to the left was provocative.
Mm-hmm.
Okay, just want to make sure I got that.
Yeah.
Okay.
Yeah.
Keep going.
Yeah, it's slightly provocative, right? So,
yeah.
And harder to do.
Yes.
So the other thing was I decided, walking is kind of uncomfortable. So let's get her out of pattern and see if we can violate some expectations and see what happens if she gets hip extension in a different way.
Yeah.
Although I wasn't thinking that it was going to show much because kneeling didn't help, for hip extension. So, so I had her walk backwards.
Yeah.
And same thing, as she went to step backwards with the left leg, it bothered her. When she went to step backwards with the right leg, not so bad. Yep. So we're kind of seeing a pattern here that the situation doesn't like extension, right? And it certainly doesn't like left thorax twisting. Correct. So kind of keep that in mind. And the reason that I'm bringing this up and bringing it up in this way is that I've seen various pieces and parts where the hip may be more dominant, the trunk may be more dominant, the lumbar spine is indicated, but it all kind of adds up when we look at differentials. And so what I really wanted to do in this podcast was just kind of take everybody on a trip down the differentials here so that you can kind of figure out what you're working with, because this is going to be the case of not a typical driver that you would think of, but a typical muscle that and how it works is going to reveal itself here. So when we think about the anterior hip, left lower quadrant, we want to think about the innervation, dermatomal innervation is going to be T12L1, right? Yes. And oftentimes that gets overlooked so much when people think of labral tears and, anterior hip frame, capsule frame. Well, she doesn't fit the mold for that. No. Because it's extension that's provocative. Yes. And they think, well, her femoral heads are banging into the front of the labrum and that's why it's irritated. And it's like, oh. So I did some hip testing, and internal rotation, FAID and, those things, the only reason they were provocative was because we were taking her into extension. But on the flexion grinding part, there was nothing.
Nothing. Yeah.
No, so it should have been positive with the flexion piece, and then when you take it into that internal rotation, a deduction kind of thing, then you get into all of that.
Right.
This was if this is a specific movement pattern that isn't fitting the pattern of a capsule, it's not fitting the pattern of a labral issue or cam injury or anything like that. Yeah.
Doesn't like extension.
Yeah, just does that area doesn't like extension. So we kind of jump back up to the dermatomal kind of piece to try to pull it together. Well, the other pieces that I think musculoskeletal, and we'll get into viscera in a minute, but musculoskeletal pieces that are also innervated is, besides the anterior front of the hip, the groin area basically, is the iliolumbar ligament. Okay, so, an irritation of the iliolumbar ligament or a perceived irritation of the iliolumbar ligament could be there. That's also a piece. And then, of course, thinking the radiolumbar area. And then we want to kind of tie it all together and think about, okay, well, what is what are the key muscles of that dermatome? And the key muscle there is going to be the psoas, the hip flexor.
Yes, yes.
And so this is going to kind of bring us into a little bit of a thing here. The psoas is if we think about it as a trunk muscle and not as a hip flexor, because remember the tendon is so small, it goes across the anterior hip to the lesser trochanter. Yes. The iliacus is much more of a hip flexor, power hip flexor than the psoas. Yep. But in order to flex the hip and walk and do the things, we have to have side bending and rotation, side bending and extension and side bending to bring, to allow rotation to occur. Because the lumbar spine doesn't rotate, the thoracic spine does. And so we have to get that side bending going in the lumbar spine in order for as to have the subsequent rotation in the thoracic spine
Mm-hmm.
for walking. So that's like back in the old days, the old days that all of the people listening are not going to know about. There's a guy named Grekovetsky that talked about the spinal engine, and he called it the psoas, and he demonstrated that people without legs could still walk because they could hike their hip up and put it down, and hike their hip up and put it down. They could hike their pelvis up, hike their pelvis up, hike their pelvis up. So he demonstrated that walking, you didn't need to have legs to walk. That it's all a core spinal,
like a trunk. Yeah,
it's a spinal
like
motion
a trunk pattern.
that creates walking. And so when you think about that and you think about what's going on with her, I want to tie the history back in just a little bit here. If she had a posterior lateral disc on the right, she is going to do everything she can to get off of that, because when we have an irritated disc, there's generally, a bit of damage to the annular fibers, and they pull off of the bone. And that creates those little teeny weeny avulsion fractures, between the annular fibers and the bone, and it bleeds, and the disc is not happy to have, it doesn't like blood that's inflammatory to it. So we get swelling.
Yeah.
And the nerve gets irritated from the swelling, and we get all this referred pain. So the brain does everything it can to say, get off of that. It's like almost like a fracture. It doesn't like compression. It doesn't like traction. It's just like tries to figure out how to get off of it. So it side bends to the left, rotates the opposite way, but we can't walk around with our head tilted to the side and looking up at the sky. So we actually drop the thorax down and deviate away from the nerve root lesion.
Yes.
And that pattern stays true and strong in these people who have had these real nerve root lesions. And I know we've seen it show up in things like, these stiff thoraxes and thoraxes that don't like to move. And when you start doing other things, it makes it all worse. And you got to get in and get back into the driver and start bringing stuff into the system here with this, because this is, and we saw this pattern, in all of the things that she was doing.
Right. So she shifted away from the side of the initial lesions, shifted to the left, translated to the left, rotated to the right. And that was a movement pattern that dominated every task that you assessed. Yeah. Yeah.
And over time, it just became sensitive.
Yeah, you think, right?
Yeah. So we want to, and we have to think about, the psoas, that's what it does. And
totally.
So a psoas can over recruit.
Yeah, it rotates.
And oftentimes it doesn't have anything to do with the fact that she had hip extension. It just wasn't comfortable. So the hip, everybody wants to go in and release the psoas, and it's like, I don't know. I think what we need to do is go in and change the recruitment pattern of the psoas. Now you can massage, if you think you can get in close enough to the lumbar spine underneath the intestines and massage the psoas, be my guest. But I have a better way, and that's what I want to talk about a little bit. Is one of the things goes, okay, what are we going to do about this?
Yeah.
And this is what makes this so cool. We talk about our progression of exercise that you talked about last time on our last podcast.
Yeah.
Which is why I wanted to kind of pull this in. So side bend to the right and rotate to the left is going to fire up the opposite psoas.
Correct.
Right, but she doesn't have great range of motion. So we have to kind of figure out how to increase the range of motion there. And oftentimes combination of movements are hard to do. So the easy, so when you have combination movements that you want to start to bring in, you want to take them down to their component parts. So you can either do left rotation or you could do right side bending. Well, with her, left rotation was provocative.
Yes, it was.
Right, because she was already side bent to the left, and then trying to rotate on top of it was provocative. So
and it's
let's don't use that one first. Let's do right side bending and just do right side bending. Yeah, exactly. And so I started with her and people like her just doing right side bending. And whenever you're upright, just
literally side bend to the
and let's see. And so we did it a few times, like 10 times, some nice, good right side bending, got her back on, kind of helped her shift over a little bit so that she could get onto her right leg a little bit, doing all those kind of, weight shifting, right side bending, just doing it a number of times, to see if that would make it easier for her.
Yes. Yes.
And then we walked. The retest exercise was walking, because that was one that she could access easily all the time. I mean, yeah, she could get on her knee, but why? That was even harder than walking.
Right.
So after we went through that sequence, 3 times, her walking improved. So something was starting to change. The pattern was starting to change. So now we added right side bending with left rotation. Is that better? And still hard to rotate, but she was getting better at side bending right, because remember in the beginning she could side bend left pretty easily because that psoas was already over recruiting on the left side. The right one was not over recruiting. It was probably actually being inhibited, first of all from the pain, and then second of all because the motor pattern didn't involve it.
Right. And I know what some listeners are thinking, because I'm just going to, when you go in, so she's left translated and right rotated, we'll just be specific here. When you go into right side bending, it doesn't necessarily mean that it's a translational movement. So I know listeners are going to be like, but isn't that left translation? No, it's not.
No, right side bending. I'm talking about bringing the lower rib cage down to the top of the iliac crest, like a C curve, what the lumbar spine does well.
Yes. Yes. I'm just, because I know they're going to be like, oh, you don't overanalyze this. It's just straight
side bending, straight side bending. And literally, I took hold of her to teach it. I, took both of her shoulders and helped her learn to do the side bending.
Right, you took out her strategy.
So she wouldn't go this way or go that way. And I just said, you're in a straight line in a box, like, front and back. All you can do is bend like straight up, like a paper doll. All you can do is bend over sideways. You can't go forward. You can't go backwards. Just to get the motion in and just to teach that, that piece of it to kind of get started. And yes, of course, quadratus is helping a little bit, and so are the abs. I get that, but we're looking at just kind of that whole area and trying to bring a little bit of meaning into a new movement pattern that would take her out of her sensitivity, which was probably coming from some overcompression over time for a long time, adaptive changes to the facet joints on the left side, and particularly at T12L1, where that transitional rotation was occurring, and firing up the stuff going down the front of the, the hip and into the groin area. So, so working on that helped her. So that's where we started, was just doing basic side bending. And then the retest exercise was get out and walk. So if she started to walk and it hurt, she was supposed to stop and do some side bendings and some breathing and some weight shift, and then see if she could, walk some more. Shortened her stride up so it was a little more comfortable. And, got her, doing those things. The other exercise for her, though, in sitting, it's really hard to do side bending. You can, so she could lean to, but in sitting, all I had her do was just think about, you'll put her hands on her chest and just do easy rotations and keep her pelvis set, so she wouldn't side bend into her pelvis, trying to impose rotation on top of it. So I had her sit onto her right, stick your hand underneath the right ischial tube, like put pressure here so that she would have to like push, kind of get onto that right side. You get off of the left side, bend over here. Of course, being right-handed didn't help, because of that pattern. But, and, just kind of get her pelvis to where she could shift onto her pelvis and be even on her pelvis. And then we just added some gentle left rotation.
Got it.
And there. So we were doing a combination of right side bending, left rotation, but we were doing them separately.
Yeah, and I think for the people who are listening, who are there, you're going to get the question, oh, well, you could have released her psoas. Yeah, but she's going to resort to the same movement pattern over and over again. That's the piece. You have to analyze the movement piece, and you need to connect the dots.
Yeah, exactly. 100%. And so I and again, I wanted to get both components, but in standing, I know people will say, well, why don't you just do left rotation in standing? And it was too hard for her to control. Too many variables, the feet, the knee, the hip, the pelvis, the head, the whole thing. And I really was trying to get her brain to pay attention to not, realizing that, no, it's not functional, but it will be functional as we move ahead. But we had to get the components in, and I wanted her to have something that would make an immediate impact to her symptoms, and so 2 times that she hurt was with walking.
Yep.
So that's why the right side bending and standing, because it was easy to access, and it changed her walk. It changed her experience.
Yep.
And then sitting when she stood up was
To
painful.
stand. Yep.
So doing some, getting some weight on her pelvis so the pelvis and lumbar spine is pretty much out of it, and then doing some general rotation, hands on the chest, so that she could, when you put your hands on the front of the chest and cross them over, you can access that thorax better. We've talked about that a lot in the podcast. Like, if we can't do weights and we can't do TheraBand, just put the hands on the chest, because we'll get input that way.
Yeah.
It helps them just get a pure thoracic rotation.
And you had her put her right hand under her right sit bone, you said, right?
Yeah.
Got it. Okay.
Yeah, just to kind of weight shift and kind of get the feel for that, and then take them out, put them
That
here.
makes sense.
So before she stood up, she did a few pure left rotations.
Oh, good. Yeah.
To help, and sure enough, it helped decrease the symptoms a bit. So she didn't have that kind of thing that went on after standing up for sitting for a long time.
Yeah.
And then the third thing, of course, and everybody will appreciate this: how long do you sit before these? I mean, is there a time limit that you can sit and stand up and not have this happen?
Yeah.
So that was, she went away to figure that out, and I said, as soon as you figure that out, drop that sitting time back 10 minutes.
Right.
10 or 15 minutes. So you're not sitting as long.
Yep.
So when they come back, there's a change. Most of the time it's like, 30 minutes is my limit. And it's like, okay, then up you go at 20, and move around. But we had to give some, ways for her to move, because walking was uncomfortable. So it's like, sitting is comfortable, but when I stand up, it's uncomfortable. And then if I want to walk it out, I can't, so that was where the right side bending came in. The weight shift, right side bending, and then the weight shift, left rotation.
Yeah.
Amen.
Was her hip in extension, quote unquote, stiff?
No.
Yeah.
No, she had good range of motion over
here.
Yeah,
that's what I think.
And again, a lot of these folks that I see around this time are, generally like 50s. Yeah. They've had something that's happened, and they're just, again, we adapt until we can't.
Yes.
And sometimes we adapt poorly. Sometimes we fray an annulus so badly that it creates a situation where we get a nerve root irritation.
Yeah.
And the best thing to do, of course, is get off of it, right? And and do the things that we need to do and stay out of patterns that really bother. So she had good therapy going through. I mean, therapy and injections really helped her. The injections brought, the nerve root swelling down. The therapy really helped her gain movement again and confidence. And they, as soon as she could start flexing without symptoms, they got her moving in that direction. So they did really, really good stuff. It's just that nothing was ever done to change the pattern at her trunk.
Right.
And so she adapted and did beautifully until she couldn't adapt anymore. And now, this area is starting to kind of get very sensitive. I don't know if we want to call it breakdown. I don't know if we want to call it degenerative disc disease or degenerative facet disease. I don't think it really matters. I think the whole idea is that she's sitting in that position all the time.
Right.
And after a while, I just couldn't do it anymore, and it was starting to give her symptoms. So teasing out the hip, making sure it's not there, that it's not a hip joint issue. That the muscles, the key muscles around the hip were fine. All of that was fine. I looked at all of those pieces, the nerve, all the, power outages. There were none of that. Reflexes were all good. It was simply kind of trying to figure out, and watching these movement patterns and get an idea that, like, why is the trunk doing this? And why is the lumbar spine doing this? And it was consistent across all movements. So that was the piece that was, it didn't change. Like when I got her on her knees, if it had changed, it'd be like, this isn't a problem with the trunk. This is a problem with the feet.
Yeah.
We've taken the feet out of the equation. Everything's straightened up. It's like, okay, back to the feet we go. But everything stayed, in standing, in half kneeling and kneeling. It was consistent from, especially the knee down and the hip and extension and half kneeling. It was consistent.
I think it's important.
I didn't do hands and knees because I didn't think it was going to tell me anything, because her hip would be flexed.
Right. Exactly.
So,
Exactly. I mean, it's pretty, when someone's committed to a movement pattern like that, it will be pretty clear across all tasks And it's a great way to, form, solidify your hypothesis, and also, I just had a thought, and now it just escapes me. Oh, for people, when you see patients who, have had these acute discs, we're so relieved. Okay, the disc is, is less hot, quote unquote, but they're left with this change. And I look at, I look at my patients every single day when they come in, and I'm assessing their center of mass before every session. It takes 30 seconds. And so for therapists who tend to see more of an acute, patients who are more a bit of an acute, a lateral shift is there for a reason at the beginning, but over time it doesn't serve. And I do think it behooves us as a profession to make those changes so the person doesn't come back and, because past movement history and past medical history always comes back to haunt people,
Yeah,
especially as you get older.
and it's a key for helping us find a new way forward. The
Yeah.
other thing that you'll see kind of typically with this is that as they bring their feet closer together, the trunk will get worse.
Yeah.
As they're further apart, it might get a little bit better, it may not.
Yeah. Yeah, exactly. Also, did you try, because I had a patient years ago who couldn't really, she had an issue with rotation. So I tricked it. I did like head on body rotation. So I had her like keep the trunk and then turn the head to the left. And I had her turn the trunk and kept it. And then
Can
I
get the
had
head
her
still.
get
Yeah.
the head still, stuff like that. I think is also.
That's definitely something you could do. And you could do it there in the clinic. Again, that violates expectations, which is kind of nice, is to hold the trunk still and have them like walk the stool around and see if they can gain it another way. And that'll give you a clue into like neural sensitivity. And if they can do it from, underneath instead of on top, but most people don't move from underneath at the thorax and trunk. They do, but it's a harder one for them to access. At home it's a little easier.
Yes.
But yeah, that would have been a great one to add in, and one that you should try. So because that gives you another way to add rotation to the system that may not be triggering the motor system to say, no, we don't go that way, because it's coming from a different direction. And that could be super important for changing a motor plan.
Yes. And did her squat get better too? I'm assuming it got better with the right side
over
bending.
time. Yeah, we went after the walking first because that was more meaningful. And then so we find the driver, right? Now it's time to load the driver. So rather than taking her into the combination movement as the second way to go. So first we started off with right side bending and then the left rotation separately in different positions.
Got it.
So now as they get better, we have to kind of progress progress this and progress and load the driver, else it's not going to change. This isn't meaningful activity. The brain's going to say, okay, that was kind of cool for a week. We're done with that. So we have to like, okay, let's add to this. So just adding things like a weight in her hand for right side bending. So not only did she have to side bend right, she had to control it eccentrically on the left. And then she had to actually activate the left side to bring it up, So we're getting that muscle to coordinate a little bit differently. And then the same thing, the little TheraBand in the, between the wrists, and then having them do the rotation. And can they control the pelvis and keep it still for left rotation and standing, and then moving it into kneeling and half kneeling, and being able to do this in all of those different positions. And the other thing was with her, she did better, holding like either a kettlebell or a TheraBand across the wrists and dropping into her squat.
I like those. I often get patients walking with weights in their hand, depending on what I want to do. Right side bend, left side bending. That's a really easy one for her to do too, because she doesn't need a weight. She could pick up anything that's heavy.
Right. And then the other thing to do is, to grab a weight and progress it on the, just hold on to the weight on the right side, like you say, walking, but don't put one on the left side.
Right.
She's already good pulling over to the left. I want her to pull the other way.
Exactly.
But you got to watch and see what happens, because some people will
they
like
counterbalance.
They'll lean over in a counterbalance. But if you progress it pretty well, they pretty much get the picture. But here's the one that's really fun to do, is to do TheraBand walking. So stand behind them, put the TheraBand on their pelvis. Okay, and you're behind them, and have them walk forward. And as they so you can pull the TheraBand in whichever
So you're
direction.
holding the TheraBand. Got
Yeah,
it.
so you're
Yep.
giving them resistance to forward walking.
Got it.
So that they have to use their muscle group differently.
Yeah, I love
And
that.
so, yeah, and so you can actually increase the stepping, and because the pelvis is now becoming actively engaged.
And you're getting that right hip
The
psoas.
trunk is becoming engaged because the pelvis is being held. And so
Mhm.
you get the opposite psoas to start to kick in that way, because they will
Mhm.
feel where they're strong moving forward and where they're not. And so then you can you just pause there. And so stepping forward on the left was easy. Stepping forward on the right was hard. Let's break that
Love it.
down, and let's do a step forward and a step back, and let's make the step smaller, but let's load it. And let's see if we can kick that in on that side, and get that to, so it would have to start to let go on the left.
I love that.
Yeah,
Yep.
and so that's kind of a lot of fun to do. And then of course you can do it going backwards.
Yes.
They can work on going sideways, and of course,
even in kneeling, you can pull her,
Side stepping to the left, believe it or not, is going to increase the right psoas, because they're going to lean to the right to step to the left.
Correct.
So, and we were already teaching a little right side bending and standing, so why not bring it into like a
right. Let's talk about varying the context, huh?
Yeah. And so, and then it's kind of fun. You can do some things where you can grab the arms, and so as they and put TheraBands in both arms tied to something behind them. So that the TheraBand is coming from behind into their hands.
Yes.
And so as they step with their left foot, they bring their right arm forward.
Yes. Yeah. Get
the resistance.
Like a protraction.
We're loading the driver.
Yes.
The thorax,
the
thoracolumbar driver, because we're doing it across rotation. So if they step left and they have to pull the right forward, we're getting that contralateral rotation.
Yes, exactly.
And in the same way on the other side, they step left, they pull with the, they step right, they pull with the left.
Yeah, I do that a lot in kneeling with the protraction, with the thing. That's a good one too. Yeah, I like that.
And you can progress that onto stairs, step up and step down, and still, like the left steps up, the right hand pulls up. The right steps up, the left hand pulls up. And then if you wanted to down the road, you could even do it going the opposite, pulling down, like, to bring lats in or something, if you feel like you need to just strengthen the whole system.
Yeah.
Those kinds of things are fun. And that's some of the things that, I think get missing when we're looking at, we've talked a lot about runners and how they need to be better on one foot and all of the different things. But I think sometimes we need to break it back up and look at just the simple fact of walking and how we can load walking.
Yeah.
And so for all of you who are dealing with pelvic health issues and people who are walking and leaking with walking, you can load walking in this way and have them use their breath. Some exhale with it, and just kind of, this is a great way. You get them going, you get them moving, and then you start loading, and this is a great way to load walking for them.
Yeah, absolutely.
They have to put a little bit more effort into the trunk and the stuff, but to do it in a way that isn't creating a downward pressure, to increase leaking.
Yeah, and this is also a great example of, the driver is the thorax, and you identified a movement pattern. What's the overarching impairment here? Is this a weak muscle or an inhibited muscle, or so you do them in movements that are meaningful and you can load. So there's a zillion ways, and I think that's what the whole beauty of the exercise progression and what we talked about last time is that you can just be creative, but you need to have a purpose. Why are you doing this? Is it to take out the hip flexor on the left, or to engage the hip flexor on the right, or to encourage more left rotation, or both? And they all may mean the same to you, but I think, especially breaking, because her trunk was her driver, her thorax, the main movement that the thorax does is rotate. It rotates, translates, right? In my brain anyway. So you're going to have an occasional patient where they have a significant kyphosis, but you want to encourage the arm movement with the rotation, because that's worth walking, and you did it beautifully in different, you can different what's the word I'm looking for, different ways, different loads, different patterns, and things like that. And I think that's really smart, because you're not going to just go release the psoas, stretch your hip, and you're all left-sided. Well, the left side's in her brain. You don't really
Yeah.
want to focus on her left side.
Yeah,
Right?
you want to help her move out of that pattern and have the
Right.
ability to move back and forth into patterns.
Right,
You
exactly.
know, we don't want her to never side bend left again and rotate right
No.
again. We want her to be able to do both
Balance.
as well as possible and in balance, which is where it comes in cool when you start loading the driver. You have to think about loading it across, you know, into the that
Multiple tasks.
rotational relationship.
Yep.
So for those of you who want to do manual therapy, you could have done manual therapy to help her gain left rotation and sideline right, you know, easy, but you have to give her a functional way to regain that muscle motor pattern, you know, to help that return.
Actively.
Right.
Yeah.
Because again, the motor system isn't going to learn unless there's a little effort put into it. We know that now about the nervous system. We know that about learning. Passive learning doesn't work. You got to put a little effort into it in order to make the neural changes that you want, in order to increase the patterns, in order to build up the gray matter, in order to do all of those types of things.
Yeah.
So,
engage the brain, engage the person. Awesome.
So
I love this.
Before we sign off, I'm going to throw one more wrench into the differential pot. Is always find out what's happening with your client, particularly in the form of GI, because if they're constipated a little bit higher up, they're holding stool in their descending colon, and that can also be a driver of left lower quadrant and groin pain. It's a visceral driver.
Visceral driver.
Yep. And you can access the viscera through the thoracolumbar area, and they may not be moving well there because they're getting, you know, visceral somatic feedback, you know, because they interact at the dorsal horn. So you may want to think about, is it cyclical? Does this happen all the time? Like, when is this worse? When is it better? So people who have more visceral drivers, oftentimes, unless they're in a total flare, you know, most of the time we'll be able to say, yeah, it occurs at this time, or when I'm, you know, they may not even have put it together, but then all of a sudden they realize, like, when I have to go to the bathroom, after I go, I feel better. It doesn't bother me as much.
Yeah.
So, you know, kind of like looking for that too. So keep that in mind, because there could be that underlying little visceral driver.
Visceral driver. Awesome. I loved this one, Susan.
Yeah, thank you. Okay, everybody.
Awesome. Well,
that's it for podcast number 115. And don't forget about our premium podcast club, toughtotreat.supercast.com. Drop us an email. Let us know what you think. Leave us a review on iTunes. It'll mean the world to us.
Yes.
And drop us an email and ask us about the podcast club if you're unsure. We're happy to talk about it. And find us on Facebook Live. We've been doing some little chats out there to you know, keep people involved. So have a great 1st of February, and we'll see you soon.
Bye, everybody.